Hi, everybody. This is CJ Wolf with Healthicity. Uh, Today, we're going to share with you a little bit of information from our Deeper Than the Headlines series. The intent of this series is to go a little bit beyond what you might see in a Department of Justice press release or an OIG announcement that, physician office X or hospital Y settled for this amount of money for the following, general reasons. And we see that a lot in some of these press releases. And so all these press releases all start to sound the same and read the same, and you don't get a lot of the flavor or the color of what really might have gone wrong. So the case I want to talk about today has to do with incident to billing. For those of you who don't know, I'll just very briefly describe that incident to billing is when a physician assistant or nurse practitioner, for example, might be working with a physician in a group practice. And there are two ways to bill for those services. Physician assistants, nurse practitioners can bill in their own name. They have their own billing provider to Medicare, assuming they've gone through that credentialing process and application process. So they can bill in their own name for their services. Medicare reimburses at a lower rate than if those same exact services were billed in the name of the physician. So a lot of practices, organizations want to bill that higher rate, of course. But to do that, you have to meet certain criteria. So, and to meet those criteria, are called incident to billing or incident to guidelines. And Medicare says that in order for services to be billed as incident to and to be covered at that higher rate, there has to be a direct personal professional service furnished by the physician that initiates the course of treatment, of which the service being performed by the non-physician, nurse practitioner, PA, is an incidental part. And there must be subsequent services by the physician of a frequency that reflects the physician's continuing active participation in and management of the course of treatment. So basically, if a patient comes in with a new problem, the physician has to see that patient, establish the plan of care, and then maybe that plan of care is 4 or 5 days or 4 or 5 weeks of care. That's the subsequent visits could then be performed by the PA or the nurse practitioner under this plan of care or this treatment plan that the physician has set up. And without the physician even seeing the patient in those subsequent visits, those services can be billed in the physician's name and get this higher rate, assuming certain criteria are met. And if those criteria are not met, you're overbilling. And you should have billed in the physician assistant's name or the nurse practitioner's name. So this particular case comes from the state of Michigan, where a health system agreed to pay over $670,000 to resolve allegations that they were inappropriately billing under the incident to rules. And there's not much more said in the press release. So what I did is I looked up the court records. I went and I found the complaint that's filed by the whistleblower. This case was a whistleblower case. Remember, under the False Claims Act, a whistleblower can file the case and they can get a percentage of any recoveries. So there's this incentive, for financial incentive at least, for whistleblowers to do this. Now, the whistleblower in this case was a physician. And that physician actually was a medical director for this organization, for the medical group at least, a member of the medical group and a board member of that medical group, and then also served as a quality and safety committee board member. So interesting. And a couple examples that they actually give in the complaint include, and hopefully this is where we're adding some color and some value for you here. The complaint states that in the course of the reviews that this physician does, as a member of the board, as a member of the quality and safety committee, this individual physician has seen a lot of records and seen some of the billing that might be going on. And I'll give you one example here of where this went awry. There was an example of a physician assistant who conducted an initial evaluation of a 73-year-old Medicare patient who was complaining about pain in the knee. Nothing wrong with that, right? PAs can do that all the time, and they can bill in their own name. But to bill in the physician's name, it has to be incident to a plan of care that physician established. And what the notes identified in this particular case was that in this particular example of this case, was that the physician assistant documented that they were seeing a new patient, and the examination was for an initial evaluation of right knee pain. So that note clearly demonstrated that the physician was not really involved in that treatment plan, right? And they don't have to be if you're going to bill in the physician assistant's name. But if you're going to bill in the physician's name, then you have to meet these incident to guidelines. It also goes on to say that in this example with this patient, that 2 months later, this same physician assistant conducted a follow-up exam. Both services, that initial one and the follow-up, were billed as incident 2 in that physician's name for that higher reimbursement amount. But the chart itself did not show that the doctor was caring for, examining, or developing a treatment plan for that patient. And then another example, there's many examples from these court records, but I just wanted to share a couple to give you a flavor of what we see beyond just the headline here. Over a 2-year period, both a nurse practitioner and a physician assistant independently examined and treated an 89-year-old Medicare patient 3 different times. And all 3 visits were billed incident 2, meaning billed in the physician's name. The physician, though, the only thing in the chart was that the physician stated they reviewed the notes, they reviewed the assessment, the order and or the procedures performed by the physician assistant nurse practitioner, and then noted in the chart that he concurred. The chart does not say that the doctor performed the examination, developed a treatment or management care plan on that initial or follow-up visit. So got to be careful here. These are really good examples, though, of where you could go awry, or you could have some missteps as it relates to incident to billing. Hopefully this has been helpful to kind of give you a little bit more color beyond just the headline of, in this case, health system pays $670,000 to resolve allegations of misuse of incident to billing rules. Thanks for listening. We hope you will listen again for our next episode of Deeper Than the Headlines.